So over the next 30 minutes, we can go over advanced brain tumor imaging. That's the title of the talk, but really what we're going to talk about is, review quickly how we do perfusion imaging for brain tumors, and then I'll review some of the clinical applications of perfusion imaging related to brain tumors, specifically two topics. One, how we can use perfusion to characterize tissue and differentiate different pathologies from each other, and also in post-treatment setting, how to differentiate tumor progression from the post-treatment changes, including pseudoprogression and radiation necrosis. So perfusion imaging, as you are familiar with some of these probably, you can do them two ways, one without contrast, one with use of gadolinium contrast. If you choose to use non-contrast techniques, you can use ASL, arterial spin labeling, or IVIM, intravoxel incoherent motion imaging, which uses the diffusion of water molecules as basically a diffusible contrast mechanism to identify perfusion. We are going to focus on contrast-enhanced perfusion imaging because that's really done more routinely across institutions where you inject gadolinium, and you can do dynamic susceptibility contrast imaging, DSC, and dynamic contrast-enhanced imaging, DCE. So this is a brain tumor protocol that I used at Sinai, where me and Larry both work together. So at the beginning you basically do some of your conventional imaging, T1, flare, gradient images. Then you start doing your DCE, dynamic contrast enhanced imaging. You use basically about 40% of the contrast that you are to give to the patient for that image acquisition. It's about 5 to 6 minutes. Then you really want to wait about 8 minutes before you do the other perfusion imaging. So during that gap, we basically do T2 and DTI, or whatever the referring physician wants. Some volumetric imaging, for example, for brain lab, or surgical navigation, and then at the end we finish with dynamic susceptibility contrast, or DSC perfusion, where we give the rest of the 60% of the contrast to accomplish that. So DCE is basically a T1 weighted technique. So you acquire a series of T1 weighted images before, during, and after contrast administration. And then you measure the dynamic signal change, the T1 signal change of the tissue of interest. And then the gadolinium distribution concentration can be calculated between intravascular and extracellular space. In order to do that, you need to reach an equilibrium state. So that's why you basically need to image for a relatively long time. The minimum time, it's about 5 minutes. That's the recommendation that has been suggested in literature. So it's about 5 minutes or 300 seconds. Basically, you acquire these series of T1 weighted imaging until the gadolinium reaches the equilibrium, and then